Good afternoon. We're here in Paris at the International Myeloma Working Group. My name is Keith Stewart. I'm a hematologist at Mayo Clinic in Scottsdale, Arizona. I'm here with Professor Antonio Palumbo from the University of Turin. Antonio, myeloma is a disease of the elderly, and you've had some specific interest in this area. Would you like to tell us a little bit about your thoughts about how to define patients who are less able to tolerate therapy?
Well, yes, I think especially for elderly patients is a major issue to define who is so-called fit and who is so-called vulnerable. So from this point of view, what is important to define is one, the age cutoff. So patient over the age of 65 or over the age of 75 should be divided into different categories. Then we should also define which type of comorbidity are present, such as cardiac, pulmonary, liver, or kidney comorbidities, and this should represent another alert. And finally, we should be aware that every time we see a serious adverse event, this is a third alert to give us more attention, and especially to start a significant dose reduction in the different drugs we are delivering. So we should modulate the dose of those drugs according to age, presence of comorbidities, and eventually occurrence of serious adverse event in order to avoid too much early discontinuation. And because we already know that too much early discontinuation is causing lower dose intensity in the general treatment and less efficacy.
So clearly you're favoring dose modifications in less healthy patients, more frail patients. I think you published this in the New England Journal recently, is that correct?
Yeah, we started in that review to publish, let's say, a table where we suggested dose modification according to the occurrence of comorbidities, advanced age, or even occurrence of serious adverse event during your treatment schema.
And just so the viewers can find that, when was that published, the table with dose modifications?
Basically, well, actually less than 1 month ago. So
in
the New England
in April
Journal.
this year,
Yeah.
2011. And so, Antonio, in your own practice, what do you do with regard to the dosing and maybe also the duration of therapy with lenalidomide and bortezomib?
Well, certainly for the doses of lenalidomide, we start with around 25 milligrams per day, 21 days on, 1 week off. And in case of one of those alerts, we reduce the dose to 15 milligrams. And if a second alert is coming, we even further reduce.
What do you mean by alert?
I call alert one of those occurrence of serious adverse event during treatment or advanced age or comorbidities. So if you have one of those signals, basically we try to reduce the dose from the beginning or during treatment.
So for lenalidomide, you start at full dose and back off based on toxicity.
Well,
except
if
if
you
they're
want,
very elderly, perhaps.
if you want to make an example, for example, you might see a patient that is, let's say, 85 years of age, and at that point I wouldn't start at 25 milligrams. I'm already starting at 15. And then, if during treatment you might have a grade 4 thrombocytopenia, at that point you even further reduce. We first wait recovering to grade 1, and then we further reduce to 10 milligrams.
And since we're on lenalidomide, tell me about duration of therapy. There's been a number of studies published recently on using lenalidomide for maintenance therapy. Maybe you could, what do you do in your own, or what is your feeling about how people should use maintenance therapy?
Well, my personal opinion is that maintenance should be used until relapse, that generally speaking, especially if you use on a long term one of those novel agents, is quite important to have a continuous treatment because the moment you stop the treatment, you reduce the efficacy of your general schema.
Do you place any limit on how long you would treat for, or until
the moment, generally speaking, both for bortezomib and lenalidomide, at least in our trial, the moment we decide to use a maintenance approach, we do it until progression.
So this has been studied by you both in elderly patients, but also Dr. McCarthy has reported this in younger patients, and both, as I understand it, show a fairly significant improvement, not just in progression-free survival, but now at this meeting it will be presented that patients actually live longer in the McCarthy study. In that context, there have been some reports of second primary malignancies occurring. So can you tell us about the risk-benefit ratio for lenalidomide based on these trials?
First of all, I would like, first, as you correctly mentioned, Dr. McCarthy is presenting here at this meeting data showing survival advantage in patient receiving maintenance. From an efficacy point of view, I would like to point it out to make a sort of comparison that in a schema like a VMP, you have 30% CR rate, but your PFS is 24 months. In a schema like MPR, you have 15% CR rate, but with the addition of maintenance, the PFS is going up to 31 months. So this is giving us an idea.
PFS being progression-free survival.
Being progression, yeah. And this is giving us an idea of how much is important a maintenance approach to prolong the remission duration, because in the second example, our CR rate was 50% at the previous one, but with the addition of a maintenance approach, the remission duration was significantly prolonged.
The common theme seems to be to use lenalidomide, perhaps even at lower dose if necessary, but to keep patients on it for a long period of time.
That, I think, is crucial, and one of the very key message to leave to the physician is that, especially for the elderly, the frail or the vulnerable patient, is very important to keep those patients on treatment, because the risk we usually run is to induce some severe toxicity and as a consequence go to discontinuation, and at that point we basically lose all the efficacy.
So you don't sound terribly concerned about the reports of second cancer?
Well, the report of second cancer, we are going to present here some data at this meeting on a large series of subjects, over 2,500 patients. Today, the risk is totally acceptable. There is an increase in secondary malignancy, but the increase is low, and certainly when you compare the risk of death from myeloma versus the risk of a diagnosis of a secondary malignancy, is the risk of dying of myeloma is between 4 to 10 times higher.
Last question, we talked all about lenalidomide. Just briefly, for bortezomib, do you suggest dose reductions that might reduce neuropathy, for example?
As for lenalidomide, also for bortezomib, we use basically the same idea. We might start bortezomib on a twice-weekly dose, and basically we might immediately reduce to once weekly if it's needed, and as a second step, we do reduce to 1.0 milligram per square meter, always on a weekly basis.
Do you have any other final parting thoughts, or do you think we've covered the key issues?
Well, as elderly patient is concerned, I think we cover all the issue. It's very important to keep those patients on treatment. It's very important to avoid significant toxicity. And especially in those patients, I think continuous treatment is another key factor.
Well, thank you very much for your time.
Well, thank you.